Welcome students to the topic adrenergic antagonists. So these are drugs which can antagonize the effect of adrenaline and related drugs on adrenoceptors. Adrenoceptors like alpha and beta or sometimes both. All of them are competitive antagonists at adrenoceptors. So this session will be dealing with the alpha blockers in detail. Before we go into the alpha blockers, you need to know about the function of alpha receptors. Let's just brush through the function of alpha receptors, which you studied previously. So, as you know, alpha receptors are of two types, alpha 1 and alpha 2. Alpha 1 usually mediates the contraction of the smooth muscle. There is vasoconstriction of the blood vessel, which can increase the blood pressure. In the GIT, it can produce intestinal relaxation. In the eyes, it will produce meiosis, mainly by pupillary contraction of the radial muscles. In functions mediated through alpha 2, they usually inhibit the transmitter release, that is by presynaptic alpha 2 receptor, and by acting on the alpha 2 receptors in the brainstem, they can decrease the central sympathetic flow. It can also contribute to vasoconstriction, and they can also decrease the receptor release. Alpha adrenoceptors are drugs which can inhibit the adrenergic response, which are mediated through the alpha receptors. We saw the function of the adrenergic receptors, alpha 1 receptor in the previous slide. So, alpha blockers or alpha adrenergic antagonists, they can inhibit the adrenaline responses mediated through the alpha receptor. Here is the classification of alpha adrenergic blockers. So we have, it is mainly divided as non-selective and selective. Non-selective means it can act or it can block both alpha 1 and alpha 2 receptor. Selective means it can either block alpha 1 or alpha 2. So coming to the non-selective, you have reversible, that is phentolamine and tolazolic, and then you have irreversible phenoxybenzamine. Selective alpha blockers, we have alpha 1 blocker, alpha 1 selective alpha blocker. That is drugs which can selectively act on the alpha 1 receptors without much action on the alpha 2 receptors. We have prazosin, doxorubicin, terazosin, tamsulosin, and silodosin. And then you have alpha 2 receptor blocker, that is yohimbine, which do not have much of clinical importance. And then we have miscellaneous alpha blockers like ergot alkaloids. Coming to the pharmacological actions of alpha blockers, effect of the alpha blockers on blood vessel. So by blocking the alpha receptor, which reduces vasoconstriction on stimulation, when you're blocking the alpha receptor, it produces vasodilatation because it is blocking the alpha receptor. There is reduced peripheral resistance and there is pooling of blood in the capacitance vessel. There is reduced venous return and there is reduced cardiac output also. But the postural reflexes are interfered with. So on standing, it can produce postural hypotension, which can lead to dizziness and syncope. So tachycardia is commonly seen with alpha blockers. Let's see how. So when there is hypotension, there is stimulation of the baroreceptor reflex, which can produce increase in the sympathetic discharge, which can stimulate the beta 1 receptor and produce tachycardia. Another reason for reflex tachycardia is because of they are blocking both receptors. Non-selective alpha blockers are blocking alpha 1 and alpha 2 receptors. So by blocking the alpha 2, which is presynaptic, right, on the adrenergic nerve ending, it can promote the neuronal release of norepinephrine, which can produce tachycardia by acting on the beta 1 receptors. So after use of alpha blockers, it can abolish the pressure responses produced by adrenaline. So remember, adrenaline produces, moderate dose of adrenaline produces biphasic response. So you can see here the biphasic response, but with alpha blocker, after alpha blocker, you give the same dose of adrenaline. You can see that the pressor action of adrenaline is blocked and it produces only fall in BP due to unopposed beta 2 vasodilation. Okay, this was demonstrated by Sir H.H. Dale in 1913 and it is known as vasomotor reversal of Dale. So it was demonstrated with the help of alpha blockers. So when there is hypotension, it can reduce the renal blood flow. So it will reduce the GFR. It can lead to more complete reabsorption of sodium in water, which can produce sodium retention and expansion of fluid volume. The reflex release of renin can also contribute to this expansion of fluid volume by acting on the beta 1 receptors. Renin is released. Let's see the other effects of alpha blockers on the nose. It can produce nasal stuffiness due to vasodilatation and congestion of the nasal mucosa reacting on the alpha 1 receptors in the nose. By blocking the alpha 1A receptors, which is mainly present in the bladder and the prostate, it produces smooth muscle relaxation of bladder and prostate, which can improve the urine flow, which is highly useful in benign prostate hypertrophy. That is the effect on the urinary bladder. Next is on the uh, vas deferens and ejaculatory ducts. Okay, so alpha blockers inhibits the contraction of vas deferens and ejaculatory ducts. So this blockade can result in impotence and failure of ejaculation. On the eye, it produces miosis. Remember, adrenaline produces mydriasis. So by blocking the alpha receptors in the radial muscle of the eye, there is loss of tone of the radial muscle of the iris, leading to miosis. That is constriction of the pupil. And in the GIT, there is increase in the intestinal motility due to partial inhibition of relaxant sympathetic influences, which can produce nausea, vomiting, and diarrhea. So coming to the therapeutic uses of the alpha blockers, it can be very useful in pheochromocytoma, hypertension, benign hypertrophy of prostate. It can also be used in congestive heart failure. First is pheochromocytoma. So pheochromocytoma is a tumor of adrenal medullary cells where excess of catecholamines are secreted or released. So this catecholamines can cause intermittent or persistent hypertension, palpitation, headache, and sweating. It is usually diagnosed by estimation of the metabolites of catecholamines like vanillin mandelic acid, normetanephrine. Phentolamine test can also be performed as a diagnostic test where you inject phentolamine 5 mg IV in a recumbent patient and a fall in BP more than 35 millimeters of mercury systolic pressure and 25 millimeters of mercury diastolic pressure indicates pheochromocytoma. Usually, surgical removal of the tumor is a first line approach, and phenoxybenzamine can be used as a definitive therapy for inoperable or malignant tumors. If the tumors are inoperable or malignant, you can give phenoxybenzamine as a definitive therapy. So preoperatively, phenoxybenzamine is given orally for 1 or 2 weeks, which can be infused by IV. Other than phenoxybenzamine, prazosin can also be used as a definitive therapy. When you are contemplating surgical removal of the tumor in pheochromocytoma, we can give phenoxybenzamine preoperatively, orally for 1 or 2 weeks, and infused IV during surgery. What is the rationale of this? It is because due to excess of circulating catecholamines, blood volume is low because catecholamines can shift the blood from the vascular compartment to the extravascular compartment, which can normalize the blood volume and body water distribution. And second is during surgery, when you are handling the tumor, it could lead to excess release of catecholamines in the blood, which can rise the BP, can produce hypertension. So preoperative and postoperative, phenoxybenzamine will be preferred. And also during removal of tumor, it can produce, usually attended with marked fall in BP. So by using an alpha blocker, the volume is restored beforehand. Another indication is hypertension, where the alpha blockers, especially the alpha 1 blocker, that is prazosin, are used as a second line drug or an add-on drug. And phenethylamine or phenoxybenzamine can be used in the control of hypertension during clonidine withdrawal. Clonidine is an antihypertensive drug. So suddenly when you withdraw clonidine, it can produce hypertension, mainly because of the action of alpha receptors. So by blocking the alpha receptor with phenethylamine and phenoxybenzamine, we can control the hypertension due to clonidine withdrawal and also its reaction in patients on MAO inhibitor. The next indication is benign prostatic hypertrophy. So in BPH, there will be increase in the size of the prostate as well as increase in the tone of the prostate and bladder neck muscles. Okay, so there are two types of drugs which can be used in benign prostate hypertrophy. First is alpha 1 blocker, which can decrease the tone of the prostate and bladder neck muscles. And the second type of drugs are 5A, 5 alpha reductase inhibitors like finasteride and dutasteride, which can arrest the growth or reduce the size of the prostate. So alpha blockers, especially the alpha 1 receptor blockers, give faster and greater symptomatic relief than finasteride. But effect of the alpha 1 receptor blockers decline after many years of use and must be combined with finasteride. So alpha blockers like terazosin, doxazosin, tamsulosin are preferred. In peripheral vascular disease, alpha blockers can improve the skin and muscle blood flow in a normal individual, but it does not produce much effect or benefit in patients with Buerger disease or intermittent claudication. They can be more useful in Raynaud's disease and echocinosis, where vasoconstriction is prominent because vasoconstriction is mainly mediated through the alpha receptors, and by blocking the alpha receptors, they can be used in Raynaud's disease. So, alpha blockers like prazosin or phenoxybenzamine are useful in this condition. Alpha blockers like prazosin are considered to be first-line treatment for scorpion stinging. So it is considered as a life-saving measure when administered very early along with scorpion antivenom. Why? Because the venom of the Indian red scorpion contains a neurotoxin which can produce a massive release of catecholamines. So by using prazosin, because it blocks the alpha 1 receptor, we can inhibit the action of the catecholamines. In patients who cannot achieve erection, papaverine with or without phenethylamine can produce penile erection. So it is given as an injection into corpus cavernosum. This can produce penile erection. With that, we have the adverse effects. So the adverse effects of alpha blockers, it can produce palpitation or tachycardia, postural hypertension, it can produce nasal stuffiness or blockade, meiosis is very commonly seen, diarrhea, impotence and edema. So with that, we stop this session. In the next session, that is part 2 of alpha blockers, we'll be discussing about the individual drugs in detail. Thank you for your patient listening.